Yeah, so our speaker today is Helen Clough. She is a statistician even, in the Department of Livestock and One Health at the University of Liverpool. Her research interests focus on the application of statistical methods to applied scientific problems, especially in the fields of veterinary sciences, infectious diseases, and public health. She is currently involved in studying how statistical approaches might be used to improve pandemic response, including COVID-19. So Helen, if you'd like to take it away.
Thank you very much. So hopefully everyone can see my slides and can hear me okay. I'm hoping people will flag it up if there is any issue, and I'm hoping my Wi-Fi doesn't let me down. So I was going to say, while it's me standing here, I'm actually sitting at the moment. So it's me sitting here giving this presentation. I need to mention and credit my colleagues with whom I've worked on this work. So first of all, Marie McIntyre, who's an epidemiologist, Grace Patterson, who is working in fields of food, public health and so on, John Harris, who I think is known to many of yourselves from previous, certainly your milk series, he came and spoke at that, and then Professor Jonathan Rushton, who is an agricultural economist working in the same department as me. So we the background to this work really was when we went into the first lockdown setting, we kind of all got together and decided that there were some interesting ideas to talk about. We bring a bunch of complementary skills with our different backgrounds, and that we might be able to do some quite nice work together, looking at how we can use routine surveillance data to understand COVID risks and so on. So that's how this all sort of came about. So we've got quite a nice little working group going together. It's one of the big positives that has come out of this year, I think. So I will move on to the content of the talk, and hopefully this will work. So first and foremost, this is a talk about science. I'm very aware that this is a hugely political topic. I am not here to talk about politics. I'm a scientist, I'm a statistician, as was said by my introduction. So what am I thinking about? Well, I'm thinking, how can data that we collect every day be used to enhance understanding of an emerging situation? So where and how can statisticians and epidemiologists best contribute to this effort? How can experience shape our response to emerging threats? And this word emerging will pop up time and time again through my talk. Science in the early stages of an emerging situation where there is little data is very difficult. When there is a need to respond, it can be hard to produce an evidence-based, and this is where statisticians and so on can come in. Knowledge very much evolves over time, and I will talk again more of this as we go along. And as I said at the outset, policy and politics is a separate area, so I'm very happy to answer questions later on about the statistical aspects of this talk, but you will hopefully forgive me if someone asks a question I don't feel equipped with my knowledge to answer. I may say so hopefully that will be okay. Okay, so this was quite interesting. So when I was thinking about putting this talk together, this expression kept coming to mind. We are currently a nation of armchair epidemiologists. I mean, if I'd asked people 12 months ago, what's an epidemiologist, I would wager that most of the people I asked wouldn't have a clue what an epidemiologist did. Now, everyone knows what an epidemiologist does, and everyone, in a sense, is an amateur epidemiologist. So I thought, what's been said about this? So I Googled it, as we do, and lo and behold, the Office for Statistics Regulation, there is a wonderful little article which I commend to you, talking about armchair epidemiologists. And I will return to this at the end of the talk, looking at what the key points are that article draws out. But to focus what I'm going to talk about today, never have we, I think in my lifetime certainly, and I've been around a while now, never have we been presented with so many numbers. I've never really known anything like it in terms of the sheer volume of numbers coming out on a daily basis. So what do they all mean? And how does the average person make sense of all this numerous information? Okay, so move on. So I've just taken a few news headlines from areas, I guess, related to my own interest. I live on the Wirral, so I pulled this one up. So here we have a headline from the Wirral Globe, which was in September. Wirral Hospital coronavirus death toll increases by 2. This type of reporting has been seen throughout the pandemic at local, national and international levels. I also pulled this one out because I'm from York originally, which I think I've had that conversation with some of you before. One more patient with COVID-19 dies at York NHS Trust. And then on a larger scale, from one of the tabloid newspapers from the Daily Mirror, UK hospital coronavirus death toll increases by 90, more than double the rise 2 weeks ago. Now, many of you may have seen, I think this was when he was on the Andrew Marr show, he did David Spiegelhalter, and I think you can find bits of it on YouTube if you've not seen it. I very much recommend it to you, it's very good. Talked very much about this kind of information coming out and described it as a numbers theatre. And I think that's a wonderful expression to talk about how this kind of information is being presented. I very much urge you to go and look for that, because it's, as always, with his presentations, or his interviews, is fantastic. This reporting is not usual, and indeed, arguably, it's not normal. This is not what we normally see. What does this type of information mean? And I think it's fair to say that these constant stark summaries do feed anxiety, and they can be frightening and upsetting for people. Just to look at some different numerous information. So now an article from The Guardian earlier this month. Heart disease deaths soar in England during COVID pandemic. Charity records 4,622 excess deaths from heart and circulatory diseases since the outbreak began. Mexico reported 193,170 excess deaths through September 26. And then excess deaths in private homes soared to 30,000 since March in England and Wales. Excuse me, official data shows as pandemic drives sick people away from hospitals to die behind closed doors. Clearly, there is often very emotive language associated with these kinds of headlines. And COVID set to cause 400,000 surge in TB deaths as medics diverted. So I think it's fair to say, hopefully with just those few examples, I could have given a whole talk on some of these headlines, that numbers are everywhere and never more so than at the moment. So just to focus on these excess deaths, I think arguably excess deaths are a more comprehensive measure of the impact of a pandemic. So what is an excess death? I know not everyone works in health settings. I know you've probably seen a lot of this in the media, but just to go over it again. So when you've got excess deaths, you've got deaths from the infection itself, so from COVID-19, and deaths from other causes. And together, these are added to produce a number of excess deaths. And what this is aiming to address is to say, well, in these unusual times, how much more death do we see than normal? And from here, I'm highlighting the things that I think are important to the context of this talk in bold. So the normal is key here. So excess deaths really only make sense when interpreted against a background context. Some of these excess deaths, and funnily enough, I actually attended an event yesterday by the Turing Institute. David Spiegelhalter was talking about this very topic. Some of these excess deaths are likely to be misdiagnosed COVID. Some will be from other causes, possibly related to the pandemic in various indirect and direct ways. But only by evaluating these numbers against a context can we assess what this expression actually departures from the norm means. So what is the norm is what we're after. And that's a lot of what statisticians and epidemiologists are about, is thinking about what is this norm. So these headlines I put up again. Okay, so none of these numbers, I think you will all agree, make sense without reference to a background context. Obviously, and I would never dream of taking away from this, each and every death is tragic at a personal level, and that has a personal impact on someone or on a range of people. None of this is meant to distract from that. I do appreciate that completely. But as statisticians, to make sense of statistics and of numbers and to assess unusual patterns, so what actually makes things unusual, we really need to ask how many people would we expect to die? These examples I've given are York, Wirral, and the UK more widely. How many people would we expect to die under normal circumstances? And that's kind of where I'm coming in today with the skills I have. Proper, timely context can help us to flag up trends and anomalies. And this word anomaly is really important. So what is it that is departing from what we would usually expect to see? It's also worthy of note, and this isn't going to be the focus of the talk today, but it's worth noting that pandemic has a variety of wider consequences. So I just pulled out a few headlines related to different consequences. So job losses rose rapidly before England's COVID lockdown. Attainment gap between poor pupils and their peers in England is widening. Half of Scots using mental health services feel worse now than at the start of the pandemic, Charity says. And then there is a knock-on effect of the pandemic, which could cause extra cancer deaths due to delays within the health service. So clearly the consequences of this kind of situation are wide and numerous. So my thoughts here then. All of these statements, remember I said right at the outset, I'm here for the numbers. That's what I do, is the numbers. So all of these statements make direct or indirect quantitative reference. So thinking back to the previous one, gap widens. What do we mean by the gap widens? Risks increase and so on. This is a huge amount of information for people who frequently are not used to dealing with numbers on this level or with this frequency. It's a huge amount for people to take in. I imagine most of us sit here as people with experience of quantitative sciences, but if you don't have that kind of background, then all this constant onslaught of information can be very overwhelming. How should people then think about evaluating the numbers that they're presented with critically? And how can they begin to judge which effects have occurred as a consequence of the pandemic and which would have occurred anyway? What information should they trust? And obviously, statisticians, much of what we do is about describing uncertainty. There is a huge role for uncertainty in all of this. And we've seen numerous examples of this over the last few months where there is uncertainty reported alongside estimates and so on. That's really, really important. So just to take a sidestep before I go into the data analysis, it got me thinking, because I teach statistics and epidemiology to veterinary scientists. How are numbers reported more typically? And these are the kinds of things we would see when I'm teaching. So that is a blank screen, that's not what I want. So is sitting really, sorry, I just have to move the Zoom window, really the new smoking? Alarming new research claims 70,000 deaths a year are caused by our increasingly sedentary lives. That's even more than lung cancer. So there's a comparison going on there. The numbers are large, there is a comparison. Cancer will kill 9.6 million people this year, experts predict. Winter crisis, 11,500 people died of heart disease last winter due to ineffective flu jab and freezing temperatures. And so that number was the highest in 40 years. In all of these things, there is quantitative information, but these numbers are large, and they are, in each of these examples, reported with reference to populations. It's fair to say that in the early stages of a pandemic, if people take their minds back to last January when this situation was beginning to emerge, numbers are very small, but they are generally increasing when you're in an epidemic setting. We're not in a situation of having large amounts of data like this. And this is why people use models and so on to understand what's going on. But I think it's definitely fair to say that context is all, and I've already said this, that uncertainty is important. And then just another example, just from my mind of my teaching practice. Heart attacks and strokes. New pill halves risk and combats high blood pressure. Every 2-degree rise in temperature increases the risk that pregnant women will give birth prematurely or have a stillbirth by 5%. And then to a more recent context related to the COVID example that we're going to come on to, diabetes sufferers have double risk of severe illness or death from COVID-19. This word risk occurs frequently, and I know I've seen this in many other discussions with you guys when I've come along to other seminars and so on. The use of this word risk is common, is frequently not helpful, because what that risk actually means is not always clearly stated. And I know other statisticians, greater statisticians than myself, have talked at great length about this. What does risk even mean? And again, we're coming back to this issue of context. So what is the baseline? So a doubling of risk might be a small effect for a rare condition, but for a very common condition, maybe something becomes a much bigger public health concern. So people struggle to make sense of this kind of information. How does the reader make sense of it all? Again, context to all of these things matters. Okay, so why? Why and how does context matter? Context is important. Deaths should be set against, I'm starting to move on to my talking about COVID now. So the deaths from COVID should be set against a background risk under, in inverted commas, normal circumstances. It is very important to understand who is being affected and to identify specifically high risk groups. Obviously that's difficult in the early stages, but your data evolve. The earlier the better, because that can help to inform one's response and the things one needs to do. So context might be driven by several things. Context might relate to geography. We've seen that certain parts of the country have their first wave of the pandemic earlier than others, and then in the second wave it was slightly different again. So context might be geography. We need to understand what is happening where. Context may be time, and it may be setting. So there may be specific settings that are high risk, and all of this information evolves as time passes. So in essence, we are interested when we're thinking about this kind of situation and we're using routine data. What we want to try and understand is who is affected, when are they affected, where are they affected, why are they affected, and how are they affected. So those 5 words I think are really key. So to come to just one of our examples of what we've started to look at then. So what we're doing here is we have, so these are Office for National Statistics data listed at the bottom. There's a couple of publications at the bottom of the paper. The first one's in print. It was an article in The Conversation in April. The second one is currently sitting in my inbox waiting edits from the journal it's been submitted to. So I'm about to deal with that. So COVID-19, we're going to compare the numbers of deaths cases against background risk to spot an excess. And this is to begin to think about, well, how am I going to reference this against what is normal? Okay, so this graph is the beginning of the graph that now will be incredibly familiar to everyone. So this is the week of the year. So obviously number 1 is the first week of the year. So that's back in January. So these were the number of respiratory deaths. Okay, so it's going along, and we see as it goes along, suddenly we get to week 13 and it jumps up slightly, and then it comes back down again. So we're not really sure. As statisticians, what we always think about, and my background before I came to this was in spatial statistics, so we did this in the context of geography. When we see something that looks like it might be an anomaly, even if I can say it, we need to assess how that compares with what we would expect in an underlying population in some sense. So what can we do with this? So the deaths jump up. Does that actually mean anything? How does that compare with what we would normally see? And is there a sustained effect going on? So if you remember, week 13, of 2020 is March the 23rd, which is when the lockdown came in. So we've got week 11 and week 12 before that. So what we did was, it's a fairly simple approach. We took the number of deaths in the same category over the previous 10 years and just took an average and a confidence interval. So there's nothing rocket science about this, but hopefully it's an illustration of how relatively simple statistical techniques can provide insight. So what do we see? Well, we do indeed begin to see in this blue circle that there were, even at that early stage, there were deviations from the norm. So we had to jump up, then it came back down again slightly, but each of those is above the upper limit of the confidence interval. And if you look lower down from this as well, there is a change in week 11 to 12 in the trend by comparison with the baseline. So the black dotted line is the baseline, the red line is what has gone on this year. There is a suggestion that it's starting to move in that direction, even a couple of weeks really before the big jump. So now we've put some context to those data. So we're not just looking at the counts this year, we're looking at how the counts relate to what was going on in the 10 years before. So that's beginning to give some context and to start thinking about, well, actually what we were seeing even from week 11 stroke week 12 of 2020 possibly was beginning to look a little bit abnormal. And also what we found interesting from this plot is if you look prior to March, actually what was going on in this year was rather lower than what's been going on average in previous years. There was a big flu season, I think it was in 2015, and the death toll for that was high. So that will have brought the average from the previous 10 years up. But that said, it's only 1 year amongst 10 years, so it shouldn't have had such a huge effect. but it looks like our death toll running up to the start of the pandemic was lower than it might ordinarily have been. And that may in part then have contributed to the size of the pandemic. A study like this poses more questions than it answers. That's what's so fascinating about it, is you see things like this and think, oh, we need to investigate that. So has that kind of had an effect as well? So that's something else to flag up. And those two references are at the bottom. If anyone is interested in this work, I'm happy to share stuff with them. Okay, so this is another plot of similar data, but unpicked a bit more. So now we've broken it down into all deaths. We've got respiratory deaths. We've got COVID-associated deaths in blue. So they're clearly going up. They're starting to go up from week 11, 12, and then they start to go up much more rapidly. And we've also got deaths without COVID in the magenta. So these are here. So what's interesting about that? So the deaths which on the death certificate at least have no association with COVID-19 are also starting to increase from March the 23rd. So these are excess non-COVID deaths. So what we would probably be wanting to start thinking is, well, why? Why are we seeing these excess deaths? And obviously we are now in nearly December 2020. There has been a huge amount of discussion about this. The emphasis of my talk is that we could potentially, by scrutinizing multiple sources, we might see more earlier. It's hard to say. But okay, so some of these may undoubtedly be undiagnosed COVID. Remember, back at this point, this was a new condition. People didn't recognize the full range of symptoms and so on. So it's quite plausible. Some of those that were attributed as excess deaths were in fact COVID deaths. I'm guessing our diagnosis of this has become better as our knowledge has improved. However, some of them could also be to do with reduction in healthcare seeking behaviours. So were people avoiding going to hospital because they were afraid, or were they simply following the rules? Sorry, I need to move this to Sunday Mares. Were they following the rules? We were told to phone NHS 111 to get advice, and sometimes people may have just not gone to hospital. So there are a number of different things that could be going on there. All this does is flags up these effects potentially and suggests them worthy of further investigation. And so that's the key point really from this slide, is that routine surveillance can flag this up early, and this can be helpful. And now we're breaking the same information down regionally. So hopefully people can see the labels. So we've got East Midlands and so on. This is divided up into fairly broad scale regions. So London is this one here. So what we see is the increase in both the COVID-19 and the excess deaths starts to occur in all regions around week 13, which was March the 23rd. The increase in COVID-19 deaths is quite interesting. So if we look at the London plot, that's rather steeper, but much less so for the excess deaths. So I have no answers to this. This is something that I kind of think, well, why? Why are the excess deaths lower? What is it? Something about, were we better at diagnosing COVID in London? Was it the case that there simply were more COVID deaths? People on average, I think, tend to be younger in London, so that may well be the case. But as I said earlier on, this poses more questions than it provides answers. This kind of descriptive epidemiology can be really useful in terms of enhancing understanding. We see broadly similar patterns in the different regions, with the rate of increase in the different regions varying. So we should always be asking why. When we see patterns like this, why is this happening? What could be driving this? And it's important also to bear in mind that surveillance data are always subject to biases, and that's something that we do have to keep in mind all the time, is that these are only the cases that we're seeing. Probably the quality of the data improves as time goes on. There are all these biases we need to factor in. As we learn more, our ability to document becomes perhaps more refined. Okay, so now I'm going to move on. So that was all based on Office for National Statistics data. Here's now some information that came from the Public Health England Syndromic Surveillance Bulletin, and this is actually going back into 2019. Now, there may be nothing in this may not be at all related, but this is more in terms of a hypothesis generation and how scrutinising several sources at the same time can be really useful. So this first plot on the left-hand side is the daily cold and flu calls as a percentage of total calls. And the baselines are constructed from historical data back to 2013. And that's those documents are online. So that I haven't actually got the data for this, but this is just taken from that report. So that's PHE's Syndromic Surveillance Bulletin up to the end of 2019. So what did we see? We saw, by comparison with the baseline, numbers of calls related to cold and flu were higher than average in comparison with a historical 6-7 year average. And that's interesting because that 6-7 year average also includes a big flu season. So that's quite interesting. I put up that expression, the wisdom of hindsight, because it's very easy to see these things when you look at them afterwards. And as I say, it may be nothing to do with it, but this is quite interesting to see. And also, so if we look at this now broken down by age group, so these were cold and flu calls as a percentage of total calls within each age group. We see, so this big jump here is in the 5 to 14 year olds, and I'll return to this in a minute. So that's the big jump at this end here. And so that is from sort of 1st of December through December. So yeah, that highlights that. Now we'll look at cough, and what we see is a similar sort of thing. So this is going through November, late November into early December. Daily cough calls as a percentage of total calls. And we've got baselines again. And we've got cough calls by age group once again. And what we see is that these coughs are up here in basically school-aged children. Now, I'm not proposing that this is in any way necessarily a genuine effect, but we do know that flu circulates in children before hitting the wider population. And indeed, people may not be aware of this, but this is why we vaccinate them, because vaccinating children effectively acts as a breaker. It stops that flu strain getting into the wider population and affecting the people that may be more vulnerable to a severe flu infection. So that's why we have a schools vaccination programme. The same, we think, is true for norovirus, potentially. We tend to see big sickness and diarrhea outbreaks in schools, so as they all go back to school and so on. And then obviously it's called the winter vomiting bug. You remember John and I and Nicola, one of our students, is studying this. The same is true for norovirus, that potentially you've got this kind of effect going on. It's difficult to say. So I've put these, as I said earlier on, I want this to be a hypothesis generation. I am not saying this demonstrates X. It is difficult to evaluate isolated patterns like this when you've got other illnesses. So there is an illness which was known to have quite a high profile last year. It's called, if I can say it, respiratory syncytial virus. It causes bed blocking in hospitals and so on. And there was quite a high season for that. It's hard to separate out when you're just looking at a single data source, whether there is anything genuine going on. But potentially, it flags up a role for simultaneous scrutiny of sources. If we're looking at more than one source together, does that give us more information? So I think this is quite interesting. And then I've got another one here. So again, this is from Syndromic Surveillance. This is PHE's Emergency Department Syndromic Surveillance System. Gosh, it's hard to say that. System bulletins. This was week 12 and week 13, 2020. So this is now thinking, this is at the time round about where the lockdown came in. So what did we see? So this is providing other context now. We saw a significant reduction in the number of visits to A&E, which coincided with lockdown. So the number in week 12, so this was just before the lockdown, was actually really high in comparison to the previous year. Now, rather annoyingly, I wanted to do the same as I've done before and do an average over multiple years, but the system changed in 2018. So I've only got 2019 to compare with, unfortunately, because I don't think I can make a meaningful comparison there. But we can certainly see that in week 12, the numbers were much higher than in 2019. Some of that could be people with COVID infections going, who knows? But certainly there were lots of people being seen at A&E then. Then the lockdown comes in and it drops right down. And again, it's much lower than the previous year at the same time period. And it comes down again in week 14. And again, it's much lower. Now, obviously, these ideally you'd be looking at a moving average or something like this, because they're going to be subject to localized fluctuations. Things like Easter, bank holidays and so on are likely to influence your attendance. But again, these are things that we can look at that say, oh, well, hang on a minute, clearly far fewer people were going to A&E, is that likely to have any knock-on effects? And we could maybe start to plan for that. So, as I've said, lengthier historical comparisons are not possible because basically we were looking at different systems. Numbers were more typical before lockdown. So again, I would like to make a longer historical comparison, but I can't. But hopefully that provides some useful context. And week 13 also coincides with the first rise in excess deaths. So we then think, well, were some of those people who weren't going to A&E people that then were dying as a result of COVID or as a result of something else? It's again, it's all hypothesis generation. And anticipating this kind of effect, so learning from our experience, as I said right from the start, might be helpful for planning for future scenarios. Okay, so just putting this up here, and I think this is a really interesting point. We live in a globally connected world. So if we'd been growing up in the Middle Ages, or even much more recently than that, it would have taken us weeks to cross the planet. Now we can do it in hours. So emerging infections can spread fast. So the most sensitive tools that we can find are useful for helping us control what happens. And I think it's fair to say that combined information sources, sometimes almost not the ones you might necessarily think about using, but they might still provide insight. If we combine them, that might give us powerful information. So what else can we learn from scrutiny of multiple sources then? Well, we should be thinking about who is most at risk. And it would certainly be worth asking why a certain subgroup is more dramatically impacted. So remember I said earlier on, context might be about geography, time, setting. So it's the who's, the when's, the where's, the why's, and the how's. Okay, so this was, and I know this received some attention in the media, not from our work, obviously lots of people have looked at this, but this is just our take on bringing some slightly different context to these data. Certain occupations are at greater risk of COVID-19 related deaths. So what these numbers are is ratios of estimated age standardized mortality rates. So the reasons for this are multifactorial. They can combine exposure and they combine societal factors. And again, a comparison against a baseline is important. So we need to be asking in each of these occupational groups, what do the death rates look like normally? So if we look at this, so what did we find here? So in SOC is your, I can't remember what it stands for, but it's your occupation, standard occupational category. If you were female and you were in an administrative or a secretarial occupation, so that's this top box here. I know there's no statistical significance on these, but it's useful as a yardstick comparison. Your risk, essentially, this measure of risk comes down by comparison with females in the whole population. And similarly in skilled trade occupations. So maybe these were people who were more able, and in males, the same skilled trade occupations. Maybe these were people who were furloughed. Maybe they were people who were able to work from home. It kind of makes sense in the context of the types of jobs they are. However, if we look at other contexts, so for women in caring, leisure and other service occupations, the number does look slightly higher. So this ratio of ASMRs. For males in caring and leisure and service occupations and sales and customer service occupations, again, these rates are higher. So again, so now we're trying to compare with a baseline of what would normally be seen in those categories. And that's kind of then trying to factor in aspects of context to these data. So some of this, I mean, this kind of makes sense. If you're in a caring or a leisure or service occupation, you might have a more outward facing job. You might make more contacts. And we know that COVID is an infection or SARS-CoV-2 is an agent that spreads via close contact. So it might be harder in those kinds of jobs to avoid those kind of contacts. So again, this is all providing useful context to these numbers. And these are quite nice graphs. So these, now what do these reference? So these are taken from these publications. We've got two versions of these with more up-to-date data. And this was the focus of our conversation article. When we looked at these data, The patterns of illness and death evidenced by comorbidities mimic those which were going on prior to the pandemic. So what do we see? Right, so as you age, it's a lot to take in this plot. I know that each of these different colours represents a different or set of conditions. So as we age, so this blue one here, so these are males on the left-hand side, this dark, well, medium blue, there's lots of blues. This blue one here that my mouse is pointing at, these are people with no pre-existing condition. So obviously there are no numbers on these are percentages, but your probability of having no pre-existing condition lessens as you get older. And that kind of makes sense because as we get older, we're more likely to have pre-existing health conditions. These come with age. As we get older, so this one here is dementia and Alzheimer's. Conditions such as dementia and Alzheimer's is the green, and this peachy orange is ischemic heart disease. So as we become older, they become more prevalent as comorbidities. So these are comorbidities, sorry, for people that have died with COVID. So these are the comorbidities that were listed on death certificates. So what we can see is that the profile of these comorbidities is changing, and that's true for both males and females. So with females, again, we see this much higher number of dementia and Alzheimer's. Interestingly, ischemic heart disease doesn't feature quite so highly. Men are more prone to ischemic heart disease. When you're younger, the absolute numbers obviously in these categories are much smaller. One significant comorbidity when you're under the age of 44 is obesity in these data. That gets less as you get older, but that may well be because you move from a category where your leading comorbidity is obesity into a category where your comorbidity is ischemic heart disease. Clearly, these things are linked with each other. And also in the younger age categories, one thing that was quite interesting coming out in women, now if I can find it, was it? No, sorry, it was in men. Cirrhosis and liver disease is a big one in younger men. That disappears. It may either be because you've progressed to another condition or you are effectively removed from that population because you're no longer around to die from COVID. So there's a lot in these plots, which I think this is really quite a nice way of displaying these data. So it's not complicated statistics, but it's a nice graphical illustration of what's going on with those comorbidities. What comes across from these is two overriding things. First of all, COVID-19 selects pre-existing ill health, and it selects for increased age. Now, this is now well documented. We produced these plots in April, so perhaps these might be the April-May data. We certainly did the same with the March data. So this kind of pattern was evident really early on from routinely collected surveillance data. So that's quite helpful to see. And the comorbidities in younger groups differ. There's been a lot of publicity, and I'm not going to go into this into a huge amount of detail, largely because it's not something I've studied in a huge amount of detail, and I stick to what I've studied, but there have been demonstrated disparities in Black and minority ethnic communities. They've been disproportionately affected. The reasons for this are complex and they're only partially understood. Potentially there's greater occupational exposure, there may be greater social disparity. There is also a smaller sample size for this population. I thought smaller is smaller, but you know what I mean. It's smaller, so that has a bearing on things. But it's important, certainly, and I will come to this in my next few slides, that the widest spectrum view of public health is maintained to understand effects of this nature and to protect vulnerable populations, information about which emerges as a pandemic evolves. So I'm starting to, where are we, 22? So I'm starting to come to work my way gradually towards a conclusion. In terms of the sum here, I mean, pulling lots of different data sources together at once, I think the whole is greater than the sum of its parts. So if we scrutinise different data sources at the same time, potentially we are in a more illuminated position. So to start pulling up some closing thoughts then. As I've said, as I've been going through, there's nothing fancy here. This is not rocket science statistics. These are just graphical displays, hopefully chosen well. The statistical analysis doesn't have to be complex to provide insight. Careful contextualization of data coupled with pertinent data descriptions can reveal much. And I think this is a really, really important one, and I've been saying this for quite a long time. Numeracy should be a priority for all societies. There was a very interesting study, I don't know whether anyone saw this recently, it's particularly important in the era of social media. There was an interesting study which I've referenced at the bottom, which said that one of the greatest predictors of susceptibility to fake news is a lack of numeracy. So if that doesn't place numeracy at the top of the agenda, then that would be a bad thing, because I think it clearly, there is a lot of fake news about, there's a lot of misinformation. If we can empower people to be able to deal with that misinformation and not react to it, then if numeracy does that, then that is a good thing. The media has a huge and positive role to play. I've seen some fantastic examples of journalism throughout this whole experience, and it makes one realise what a powerful position the media is in to influence people's behaviour to the good, and to equip them with the right facts and facts-based information rather than misinformation. I think my view is that a pandemic is most helpfully viewed as a multivariate system. Interventions to tackle one effect, which might be the infection, which is the most immediate effect, are likely to impact on others. And the monitoring of surveillance sources from a wide variety of perspectives is the key to understanding what's going on. And so is the provision of timely, transparent data. Again, I don't know if anyone's had a chance. I know we see snapshots of it on the news and so on, but the Public Health England dashboard is fantastic. It's a really great resource, updated in real time, and there's lots of information there. Similarly, the Office for National Statistics, their data take a little bit longer because they're finally confirmed causes of death, so that takes longer to filter through. But again, it's been made available very timely, and it's very accurate, high quality data. So we're in a very fortunate position from that point of view. It's essential that an emerging infectious agent is viewed as an integral component of broad spectrum public health perspective. So I talked a bit about comorbidities. Those comorbidities should be considered as part of that public health strategy alongside the infection. And yes, so public health must view infectious disease against a wide background context. So this was just something that came to me towards the end. Can we use other contexts to aid in the anticipation of unexpected effects? So I thought, let's just go and look at some other diseases. So this was an influenza update. This is a snapshot of a paper. What did I pull out? So this was just an update on a review of currently available vaccines. This statement here struck me. Although influenza can infect individuals of all ages, most influenza-related deaths occur in the elderly and in those with underlying cardiovascular and respiratory comorbidities. So again, with influenza, there is a role for age and there is a role for comorbidities. Similarly, tuberculosis, non-communicable disease comorbidity and multimorbidity in South Africa. What did they find? High non-communicable disease comorbidity and multimorbidity was found among TB patients, and that was predicted by socioeconomic disparity. So what can we potentially anticipate through the studying of background or even historical context? Which risk factors are new? In a way that's akin to hazard identification in risk analysis. I mean, I know you guys know a lot more about risk analysis than me, but I've done foodborne risk assessment. I've worked on that quite a lot. And one of the first things we do is what are our hazards, identifying our hazards and so on. History has much to teach us, and it's funny, I wrote this before I actually went to this event yesterday, and so Lord Robert Winston was speaking at it, and this was exactly what he was talking about. So he was talking about the experience going back into history of how Yersinia, so that's the causative agent of plague, Yersinia pestis, how experiences from that were similar to current experiences and differed from. So what can we learn from that? And with that in mind, we've also got another paper in submission, which I've referenced at the bottom, Societal Impacts of Pandemics, Comparing COVID-19 with History to Focus Our Response. So that's in submission at the moment. So my closing thoughts then, having said I was closing, I've been closing for ages, but I'm closing now. So I think none of this is simple. I think this is really, really difficult science. And when you're faced with an emerging situation, it's about as difficult as it gets. Information that comes out at the outset is always minimal. Remember, you're often starting out, if you remember where we were back in January, there was a couple of cases, and I think the first death came at the, I can't remember exactly what the date was, but late February, early March, and then these numbers start to grow. We must use the wisdom of hindsight positively. I think it's really important. This is a positive process. So what can this situation teach us about what to prioritise next time? And I think the thing I want to say, and I've heard others say the same, there will be a next time. So since 2000, we've had SARS, we've had Ebola, we've had swine flu, we've had MERS. And I'm now a plea for the discipline that I come from and in which I currently work. I work in the Department of Livestock and One Health. So One Health is where we consider animals, humans and animals all together. And I'm going to now reference my old boss, Malcolm Bennett, who used to be at the University of Liverpool. And he always used to insist that we referred to human and non-human animals. So not seeing humans as separate, we are just animals. And there was a study in 2001 which showed that an estimated 75% of emerging infectious diseases are zoonotic. So what do I mean by zoonotic? If people are not familiar with that term, basically they can cross the species barrier. So they can come from animals to humans and back again. So this is something that we always need to be bearing in mind and thinking about how humans and animals interact. So that One Health perspective is really important. So the early contextual, I hope I've said enough in the last 45 minutes to convince you that the early contextualization of public health data is critical to the understanding of who gets sick, when they get sick, and why they get sick. It can then ensure a measured, targeted response. Hopefully, it can improve one's ability to anticipate indirect consequences of a pandemic, because there are always things that happen that you weren't expecting. And understanding the health of the population you're dealing with is critical to assessing risk. And then finally, a future outbreak response will be improved by better understanding of connectivity between disease monitoring systems, and that can aid interpretation of disease risk patterns, facilitating nuanced mitigation measures. And I'm just going to, I use this one in teaching as well. I like this one for teaching. So this is a line from Donald Rumsfeld. It always makes the students laugh. There are known knowns, things we know that we know. There are known unknowns, that is to say, there are things that we know we don't know, but there are also unknown unknowns. And these are the things we don't know, we don't know. And for me, I think kind of the message I'd almost like to leave you with is that in emerging infectious diseases, the unknown unknowns pose the greatest challenge. So I said right at the outset, I would come back to this armchair epidemiologist piece, which I think is really nice. Go and have a read of that. So these are thoughts from Ed Humphreys, who is the Director General of the Office for Statistics Regulation. And what points does he make in this article? So as I kind of read this, and I think, well, in terms of me being a statistician, how can I help in this kind of setting? So he said, we are seeing the power. Well, first of all, he said, we are all armchair epidemiologists now. So people are watching the television every day and they are soaking up the numbers. And when I saw David Spiegelhalter speak, he said, people are hungry for information. They want the information. So we are seeing the power of statistics to inform and to paint a picture. From my point of view, there has never been a better time to be a statistician. Trustworthiness really matters. It is crucial to be clear what stats do and what they don't say. We shouldn't forget about data quality, nor dark data. That will come into your uncertainties and so on. And equality of access is at the heart of it all. And I think those are really nice points in terms of thinking where numerous scientists such as ourselves can contribute to such an effort. So I think that is probably the end. So thank you very much for your attention, and I hope you found that interesting.
Yeah, thanks, Helen. That was a really interesting talk. We're going to move on to questions now. And the way we do it is, if you've got a question, please click the raise hand button. That's in the participants menu. And you should see that option on the right side when you open the participants menu. Otherwise, if
stop sharing now, can't I? Shall I stop sharing?
Yeah, sure. Otherwise, if you want to ask a question and you do want to say it yourself, you can post it in the chat and I'll read it out for you. Yeah. So I was wondering, myself actually, do you have any, I suppose this is slightly tangential, but do you have any issues trying to communicate this beyond, I suppose, academics? Because there's a lot of misinformation, and it has become, I don't want to go into the political side of it, but
yeah,
obviously
sure, no,
contentious. But when you do find yourself communicating this, do you get pushback, and do you have any ways of dealing with that at all? Or
I mean, I think people are generally very receptive. I mean, I think provided one can, if one can talk, rather than talking about a number, for example, if one can talk about a range and can kind of try and present the information as a range, then that can be very helpful. I think the concern with numbers is people believe numbers, and I know there's numerous examples of this. So if you say, well, I don't know, the average risk is 20%, the confidence interval goes from here to here, the confidence interval bit will be lost. And so the 20% is what is seized upon. So I think that's very much an open area. I mean, I find the whole area of risk communication fascinating. I think, yeah, and I think hopefully the work we've done in terms of thinking about context can help, because I've been frustrated by the one death here, two deaths here. What does that mean in terms of what we would normally expect? And I think if you can provide a context to that, then hopefully that helps people. That was, in many ways, was kind of the motivation for why we did it.
sure. So provide context and
Yeah.
look at a range, really. Yeah. Sure. Thanks. Adolphus, you have a question. Do you want to unmute and ask?
Yeah, thank you so much, Simon. So first of all, good afternoon, Dr. Helen, and thank you so much for your insightful discussion this afternoon. I really enjoyed it thoroughly.
Thank you.
And no worries. So on my side, I've actually two questions, but we will go through them one by one.
Yep.
So my first question is as follows. So in one of the I think these days, in newspapers, and especially in the context of COVID-19, we've been seeing a lot of the word. Experts say that this happens, and experts this, experts that. But we have to also understand that because different experts can have different viewpoint of things, and and due to expert elicitation, all that. So, in your view, would you would you agree that this word expert has been sort of overrated, and it can be very, very misleading in reporting things such the statistics in COVID-19 and whatnot?
Sorry, I think you broke up slightly. Could you just repeat that last part? Sorry.
Oh no, basically it's just, in your view, would you agree that the word expert has been pretty much overrated, and it can be very misleading, in communicating what is actually,
Okay. Yeah, that's an interesting question. So you're asking me, so is the word expert overused?
Yeah.
Is that am I interpreting you correctly? Yeah. Okay. So I mean, scientists are experts in what they do. So do you, I'm not sure I really understand. So are you saying that newspapers perhaps overuse the word expert, or what does an expert actually mean? Is that
sort of. That's basically what is pretty much what I'm trying to ask. Yeah.
Sure. I mean, I certainly, in terms of the work that I've seen, I trust the expertise of the people who have done the work. I'm always the first to say, if someone asks me a question that touches on something I don't know anything about, I will say I'm not an expert in that. I'm not sure I'm really answering your question very well, so I'm sorry. But, yeah.
Yeah, because I personally believe that because when newspapers use the term, like experts say, that there's always this notion among readers that this is probably the absolute this is probably the absolute phenomena and all that. But we have to also acknowledge that different experts could have different viewpoints on things.
Yeah.
And so that's why I felt that this word is not only overused, but it could be very, very misleading, especially in a situation like this.
I mean, I think it's interesting. I said I was at the talk yesterday at the Turing Institute. David Spiegelhalter talked about this. So there was an example where different groups of experts had all produced different ranges for the estimate of something. And his argument was that a confidence interval alone is not uncertainty. So part of uncertainty might be a confidence interval, but the fact that different experts have produced different opinions is also part of your uncertainty. You've got different types of uncertainty. So maybe is that the issue here? I mean, sorry, if anyone else wants to, please do.
Just interject on that, because a few of us attended this sort of BMJ event on Friday, and they had a session that was talking about communication. And there were several journalists on the panel, and one of the things that they said is that they found it difficult because all of a sudden it was scientists arguing with each other.
Yeah.
And it
Yeah, that's
wasn't
a
the job
problem
of the
as well.
journalist to look at the published consensus and talk about that. It was the journalist to mediate the fight between the scientists.
It's interesting because I think my feeling is scientists should disagree with each other. That's the nature of being a scientist, and that disagreement informs the evidence base. But it's kind of how one communicates that fact that experts disagree isn't necessarily a bad thing. It may just reflect a lack of state of information. So often with certainly early on in a pandemic, I mean, using models to describe the pandemic is a good example of that. Obviously, I mean, I like quoting George Box when I'm teaching, there is no such thing as, well, all models are wrong. Some models are useful. People are going to produce different models to address the same phenomenon. Because if they produce different results, that is not necessarily a bad thing. It's just that different groups are bringing different perspectives to the table, and that is all part of this uncertainty, isn't it? It's just different types of uncertainty. I mean, does anyone else have anything to add to that?
Yeah, I just maybe have a comment that actually, like, this is the hardest thing for people who are not in science.
Yeah.
To just connect it with what Adolphus was saying, that with experts, that's the thing, that as soon as someone reads that experts said something, it's absolute truth. And then as soon as they see another article from describing opinion of other expert, then they can't really deal with that because they already sort of decided what their opinion is. They are like emotionally invested in that opinion, and then they just can't really process that if they don't have that sort of background in science or just thinking critically in general. And I would say large portion of population doesn't really know how to just deal with the fact that things are not certain. So
I'm interested in your perspective, Nicola, as a psychologist by background on that as well, because I think psychologists have much to offer in terms of this, how people react to that kind of thing.
Yeah, because this issue is actually creating more chaos rather than giving a direction. Kind of thing. So yeah, it's absolutely like pretty much what's going on here, right like in recent times. Okay, just in interest of time, I'll just proceed to the second question that I have. All right, in one of your closing statement, you have shared that a pandemic is most heavily, it can be modeled as a sort of like multivariate system.
Yeah.
Can be viewed as a multivariate system. May I just clarify, and if you could, possibly elaborate more on this point, because it really interests. Like, okay. I got interest in that point.
Yeah, I suppose I don't mean modelling in the modelling sense. I mean more in terms of viewing. So the deaths from the infection or people testing positive with the infection are one consequence of the pandemic. However, there are other consequences. So for argument's sake, people who don't seek healthcare and then die from something else, or people who lose their jobs as a result of the pandemic. So there are multifaceted dimensions to what happens with a pandemic, of which the deaths from the infectious agent are only one. And I think, that's an interesting point, actually, whether there is any formal modelling of that multivariate system that could be done. That's only just occurred to me now when you've said that, but I was meaning it more in kind of a generic sense, that you viewing it from multiple perspectives is helpful.
Yeah, indeed, because I was actually thinking of because we have all this like Bayesian model, belief models, and all that could definitely be applicable to pandemic issues. So it'd be interesting to see how this all pans out. Like really interesting.
Yeah, there will be relationships between different things. So you do one thing to control the infection, that then may impact on economic aspects and so on. And so there are likely to be correlations between things and interesting. Not complicated, but could be, from the point of view of people, I know a lot of you guys work in big complex models. That might be interesting. Yeah. Thank you.
No worries. Yeah, but thank you so much for your insights and your viewpoints on the discussion. So I'll not take anyone else's time, and thank you so much once again.
Thank you.
Yeah, thank you. So the next question I've got lined up is Nick. Do you still have your question?
Yeah. Thanks to Helen. It was interesting. I was just wondering what thoughts you have on the sort of same ideas when it comes to sort of I think it's apparent at this point, the next phase of the pandemic, as it were, is that in the new year, it is going to start being these mass vaccination programs, which will come with side effects. And just quickly Googling and looking at the Oxford paper, that I haven't read it, gives sort of stuff like pain and headache and stuff like this, and some of which are described as severe. And so I'm sort of wondering what thoughts you have is actually, so they're talking about relatively small numbers compared to the millions that will be done. Is that how that could be communicated upwards? So actually a lot of people that will be vaccinated will have side effects, and how those side effects interact with comorbidities and stuff like that.
Yeah, I mean, I'm interested in the question. I'm not sure I'm really equipped to answer it, because that sounds like a total cop-out. It's not, but I really don't know very much about vaccines. I mean, I can see what you're saying in terms of, so if you've got something that's quite small, but you transfer it to a large population, is that what you're asking?
Yeah.
Yeah. I don't know. I mean, I guess you're right that the communication around that would need to be considered.
Because you can see the headline sort of straight away, the Daily Mail headline, thousands of people are bedbound after vaccine, even though that's essentially relatively fine statistically. It's minute numbers of people, but you can see where that would go, especially amongst already skeptical individuals.
I think risk communication will continue. I mean, there will be risk communication aspects to all different aspects of this until the situation eventually resolves, and this is probably just one example of that. Yeah, interesting thought. Yeah, not sure I have an answer. But...
Okay, I'm assuming that question's over. Our next question I've got is from John Fry.
Helen, thank you very much for a most interesting talk. I'm a retired physicist from the University of Liverpool, so a very different area, but also working with statistics in a different context. I'm very aware that the probability for serious illness and death increases rapidly with age. So, for example, at my age, I'm probably about 1,000 times more likely to die than a 17-year-old if I catch COVID. On the other hand, David Spiegelhalter has made it very, very clear that within roughly a factor of 2, and of course not taking account of comorbidities, roughly speaking, the probability of dying from COVID is about the same as the probability of not living 1 year longer. So at the risk of transgressing into politics, are we all, I mean, experts, statisticians, everybody, making too much of the probability of the older ones among us, myself included, dying or becoming seriously ill from COVID? Should we not rather be looking at the seed corn of our future and looking to preserve the economy for our younger generation?
Oh, that's definitely getting too much into politics for my liking, I think. I mean, I think you're absolutely right. I've seen David Spiegelhalter even speaking about this, and you're right, because it's really uncanny, the resemblance between the two graphs, isn't it? It literally, effectively, it doubles your annual risk. I think that's right, isn't it? That's what he says. Yeah. So.
May I support you, Helen? Sorry for interfering. My research from the last few months demonstrated, so I interviewed people aged 65 plus, interviewed 33 people how they experienced this pandemic. And many of them said, I don't want to watch any news anymore because it's far too frightening, it's far too depressing. And you can see probably my blog on the Risk Institute homepage. And I support John when you said, why should we look at the elderly people? And so many people said, oh, why do they care about us? They should more look at the younger one, at the children, the education and the economic side as well. So this is I think which hasn't been really transported in the news. This is really complex now. Lots of work which had to be done and which need to be done to get this information across for elderly and vulnerable people as well. So some are really frightened, and some are desperate to get out of the lockdown, but someone said, I lived my life. I'm happy what I've got before. So, but the younger generation, the economic, it takes ages to recover. Probably this.
Thank you for the comment, and apologies, Helen, for
no, please do.
transgressing.
It sounds like you're much more well equipped to discuss this than I am, because as I said, I'm coming from the numbers, but please do carry on because it's really interesting.
Thank you.
Yeah.
I might have a comment. Sorry, if there is a question, go on. I just about this point. Whenever I think about the reasons why we need to be locked down and all that, so I think it's not only about what we are seeing, but also maybe interpreting what could happen. And I think there is also, when you look at mathematical models of COVID, from at least what I gathered, I mean, I'm no expert, but at least the arguments that I read are that since COVID takes so long for even people who are who just they might not die, but they have like severe COVID, so they stay in hospitals very long. So what happens is, so the main reason is really not overwhelming the hospitals, and they can be overwhelmed because the COVID takes so long. Like even if the proportion of sort of people dying, like when you just look at overall sort of trend, like okay, there can be one number, but the number would be totally different if you put it into the context of not having the staff, overwhelmed hospitals and all that. So, you know, like I think we are not really seeing the worst case scenario. That's what I'm trying to say. So, so yes, I think we can't really just judge on, that's the thing, like context is important. Yeah, even if you just look at the numbers and also with the decisions, I think it's quite hard because I think science can't really answer those questions at the moment. So that's why it's quite hard to also like assess whether it makes sense to have the lockdowns or not, because at the moment it's more like, let's just do something because we don't really know. So
yeah, I mean that's a very good point that you make, is that once again, and this comes back to where I'm coming from with the talk, is that a lot of the decision making comes back to context, and that is a very good example of context, isn't it? So yeah.
Okay, I think Dominic.
Thank you. Mine's not really a question. I guess it's more of a statement, and just to hear what your thoughts on it are. I think along the lines of what Nicola was describing, a lot of the trade-offs that you alluded to, that some of them that Nicola were describing, make a lot of the decisions sort of way too complicated for us, for anyone really, to reduce into simple binary decisions, certainly on a national scale, but even as an individual making decisions about the way you behave. One of the things that I've kind of been quite surprised about, but I guess it sort of makes sense, is how, generally speaking, people seem to be so unable to see gradation in risk at all. And so I've seen loads of things I am going to base it on Facebook, but I've also heard epidemiologists and some kind of fairly respectable people on news programs and in interviews say similar sorts of things, not quite the same as this, but things like, if masks work, then why have we got another lockdown? If we've got another lockdown, then why are we wearing masks? And like putting everything on these kind of orthogonal, like a dichotomy between one or the other. There seems to be little appreciation of how if you wear a mask, you're not completely safe, but we're talking about kind of a small improvement. And if we all do these marginal improvements, then we can control things much better. And it's part of the problem that we have such an open academic sector where everyone comes out all the time and gives their 10 pence worth on national news programs or whatever. And really, the people that have done the best in this situation is places, particularly in the Far East, where there's kind of one message that comes from one authority and arbiter on the situation, the people that you hold responsible at the next election, or at least the people that are in charge of the country, if it's not a democracy. And isn't the problem we've just had too many scientists give too many ideas and too many opinions about too many things that they might appreciate how.
Everybody's frozen.
Oh, we can still hear you.
Dominic's frozen for me.
Yeah, Dominic's frozen here as well.
You're back. You're back.
I think it's his end rather than ours.
I was finished anyway. That was my rant.
Yeah, no, it's
So-
an interesting question or point, certainly. Yeah, I guess we do have a very scientific community. Oh, I'm losing people again. I keep losing people. I was paranoid it was going to go during my talk, but unfortunately it didn't.
I think one of the other interesting things
good.
that you said actually was around the confidence interval that you get when someone reports something like a mean or whatever. And one of the things that I have been more impressed with is this, well, partly more impressed and partly in tears with this use of the reproduction rate. And every time I've heard a reproduction rate quoted by anyone, it's been an interval. That I've not heard any mean estimate of reproduction rates. Most of the time it's between 0.1 and 0.6 or whatever. And that's been encouraging.
Yes, absolutely.
The overuse of the reproductive rate with people that are then using that to justify what their opinions are about what we should be doing is where I'm a little bit upset when you get commentators that kind of say, well, we're trying to bring down the R rate. And I'm sure if you really interrogated them, they wouldn't have a clue what the R rate really means. Yeah. And they don't understand how kind of sophisticated and sensitive a measurement something like that is, which is an average of a certain portion of the population. And so, yeah, I think encouraging signs with the R rate and signs of further worry as well, along some of the themes of your talk for me.
I think statisticians certainly are pushing for intervals to be quoted rather than point estimates, and that is a good thing. Because people, if you give people an interval, they can cope with it. I feel like I'm quoting David Spiegelhalter endlessly, but he was speaking yesterday and he said, never say the words confidence interval. You just talk about your uncertainty interval. So it's between here and here, because as soon as you start introducing that kind of scientific jargon, you lose people. And I think that's really important. You know, you've got to try and keep people on side and talk non-technically, and it's hard. It's one of the things I really enjoy trying to do, but it is hard, particularly when you're not speaking to trained mathematical scientists.
Do you not think on that R interval though, do you not think the issue would become if it was 0.8 to 1.2?
Yeah, that's an interesting one, isn't it? Yeah.
And because you see it quoted, it was quoted last week, but they've said it's fallen to 1.1 to 1.4, but it's okay, so now put it slap bang on the middle of this one.
Yeah.
Then
which is threshold. Yeah.
Because that's, or at least in terms of communication, that's what they're talking about. They're talking about want it below 1, because then the virus steadily dies out.
People will be saying is it or isn't it? Yeah.
That's when I think that.
Forgive me joining in, but I mean, quoting R is an absolute nonsense, because it's a derived quantity. I mean, all we really need to know is what the rate of fall of the number of COVID patients are, or the number of deaths, or something else. I mean, those are the important quantities. I mean, who the heck cares about R? You want to know whether the effect of the virus is increasing, staying the same, or decreasing. Sorry, I'll stop now.
No, that's, I mean, I think I've heard as well that R is less useful as a disease becomes rarer. So in terms of its statistical properties and so on, so as we see less of it, it's less of a reliable measure. Yeah, but again, I'm not a mathematical modeler, but that's my understanding.
Well, of course that makes sense, because if you've got fewer cases, you can't get a good fix on what that means. So all it is a mean, a mean of the number of people that pass on. So fewer data points, the mean becomes more uncertain. So yeah, it makes complete sense that that would be the case.
Less reliable, yeah. Yeah.
At least no hands up. If you've got any questions.
If anyone thinks of anything afterwards, you can always email me as well. You've got my email address, so I'm very happy for you to pass it on if anyone's got anything that they would like to raise.
Simon is lagging.
Oh, yeah.
Simon's frozen.
He's frozen on mine as well.
Yeah.
Thank you again, Helen.
Yeah, my pleasure. Thank you very much for the invitation.
Thank you.
Thank you very much.
Yeah, thank you so much, Helen.
Thank you for the discussion. It's been really good. So,
yes, really interesting stuff.
right.